Next, a look at the basics of organizing FHIR resources for representation in a patient's record. First, let's use the FHIR procedure resource as an example of how we might connect resources together to represent a use case for an individual patient. First, the FHIR procedure resource would include the identity of the procedure, who performed it and when, and that procedure would reference the patient who's the subject of the procedure, the condition that's the reason for the procedure being performed, the encounter within which the procedure was performed, the practitioner who performed the procedure, and a diagnostic report that would occur as a result of the procedure, all of those being separate FHIR resources that are linked to the procedure resource by server references. So there are a number of FHIR resources that are used to represent or organize the FHIR data that's part of a use case. Examples are the list resource, which might be a medication list, problem list, allergy list, a past medical history, which we think of as a list of past conditions or procedures in a patient's history, a past social history or current social history that both represent different lists. And these list resources would be used as a way of organizing data within a document or for exchange. That exchange often takes place as a FHIR bundle. The bundle resource is a way to identify a group of FHIR resources that are related in some way, either as a list or document, or perhaps a laboratory test result. The FHIR composition resource is used to identify the structure and format of a document that contains FHIR resources as the data for that document. So as an example of a FHIR document, consider this brief representation of two office encounters, one when a 12-year-old child presents to a physician with pain in the right ear for 3 days and an elevated temperature, the pain in the right ear being a condition that is being asserted by the patient, and the elevated temperature and observation made by the patient. In the clinic, the patient's found to have an elevated temperature of 38 degrees, and that is an observation asserted by the practitioner. There's also an observation of an inflamed right eardrum, and the patient is prescribed amoxicillin, which would be represented by the FHIR medication resource. 2 days later, the patient returns to the same clinic with an itchy skin rash, determined to be a result of an allergic reaction to the amoxicillin. The patient is given an alternative prescription for erythromycin. So if we look at those different FHIR resources from those two encounters, we could diagram it in this manner, where the patient and the practitioner are the same for both of the encounters. There are separate observation resources. There is an allergy resource representing the penicillin allergy. All of those resources are referenced to the appropriate encounter and could be sent as a bundle to represent a document, and would include a composition resource that would specify the way the data is arranged in that document. In the course of clinical care, it's expected that documents will be signed or attested to by a practitioner who created the document, in this case the physician. So that bundle representing the document can be signed or attested to, just as you might with a CDA document, and then that bundle could be exchanged with another system or stored in a FHIR repository. There are two other very important organizing resources, one of which is the questionnaire resource and the related questionnaire response. Many things in healthcare can be thought of as a questionnaire or a form, covering a broad range from past medical history to public health case reports, social history, research questionnaires in the course of clinical research, quality and evaluation forms, patient intake forms, forms for insurance claims, and there are certainly questionnaires or forms that are actually completed by the practitioner, not by the patient. These would include procedure reports. All of these different use cases can use the questionnaire resource to represent the items, the questions in the questionnaire, which may be simply a flat series of questions, but the FHIR questionnaire resource also enables branching logic so that if the answer to question 3 is no, you go to question 6 and so on. So the questionnaire resource is not specific to a patient. It's actually referred to as a definitional resource in FHIR. So in other words, the same questionnaire resource would be used by many different patients or practitioners. However, the questionnaire response resource, that is exactly what it sounds, the results of that questionnaire, is specific to the individual who completed the questionnaire and is then a bundle of FHIR resources. So that questionnaire response might be stored in a FHIR server where the responses could be retrieved or subject to analytics for a population of patients. I would consider the FHIR questionnaire and questionnaire response resources as among the most valuable and usable entry points for adopting FHIR. Creating a questionnaire does not require a full knowledge of FHIR nor of healthcare data or interoperability. Designing a questionnaire might only require being familiar with your own work area and some of the data needs or workflow needs in that work area that could be supported by a questionnaire or form. So I would think of the questionnaire as enabling innovation by many different individuals in healthcare, regardless of what their role is, as long as they're able to describe the need in their work area and the data that would be involved. They do not necessarily have to know the specifics of interoperability, since many questionnaires would be used locally and could be the entry point to more complex FHIR use cases for someone who's learning about FHIR.